Sore throat. Key points. Most children with sore throats do not need antibiotics. With the exception of scarlet fever type rash, there are no clinical features alone that reliably discriminate between group streptococcal, gas, and viral pharyngitis. Antibiotic therapy is only recommended for a high-risk group of children to prevent non-suppurative complications of gas infection. Background. The most common cause of sore throat in children is a viral illness. Group streptococcal, gas, pharyngitis is rare under 4 years of age. Gas can cause non-suppurative complications, acute rheumatic fever, post-streptococcal glomerulonephritis, and suppurative complications, peritonsillar abscess, retropharyngeal abscess. Assessment. Any patient with impending airway obstruction should have minimal handling and be referred early to an experienced clinician for definitive airway management. History, age and ethnicity. Oral intake. Associated viral features: cough, coryza, conjunctivitis, hoarseness, ulcers, diarrhea, characteristic viral exanthem. Blank. High-risk groups: rheumatic fever, Aboriginal and Torres Strait Islander people, Maori and Pacific Islander people. Personal history of rheumatic fever or rheumatic heart disease. Family history of rheumatic fever or rheumatic heart disease. Immunosuppressed children are at increased risk of suppurative complications. Examination. Blank. Blank. Assess. Hydration status. Fever, oral/pharyngeal ulcers, Coxsackie virus, tonsillar exudates, tender anterior cervical lymphadenopathy, hepatosplenomegaly, EBV, scarlet fever type rash, blanching, sandpaper-like rash, usually more prominent in skin creases, flushed face/cheeks with perioral pallor, gas. Red flags. Unwell/toxic appearance. Respiratory distress. Stridor, trismus, drooling. Hot potato voice, muffled voice associated with pharyngeal/peritonsillar pathology. Torticollis. Neck stiffness/fullness. In the acutely unwell-looking child, consider alternative diagnosis and/or complications of gas pharyngitis. Management. Asterisk supportive management, see treatment section below. Investigations. Throat swab is not routinely recommended for sore throat, with the exception of the high-risk group. Consider other investigations if suspected suppurative complications, relevant imaging. Hepatosplenomegaly, FBE, monospot, plus/EBV serology. Streptococcal serology has no role in diagnosis of gas pharyngitis. Treatment. Supportive management is adequate for most sore throats, including scarlet fever. Simple analgesia, c. Corticosteroids can be considered in patients with severe pain unresponsive to simple analgesia. Dexamethasone 0.15 mg per kilogram, max 10 mg, oral/4/IM as a single dose, or prednisolone 1 mg per kilogram, max 50 mg, oral as a single dose. Maintain hydration, c. Admissions for analgesia and hydration are not commonly required. Antibiotic therapy for suspected group streptococcal pharyngitis. Antibiotic therapy is recommended only for high-risk groups. Antimicrobial recommendations may vary according to local antimicrobial susceptibility patterns. Please refer to local guidelines. Antibiotic. Phenoxymethylpenicillin. Root. Oral. Dose. 15 mg per kilogram. Max. Duration. 10 days. Amoxicillin. Oral. 50 mg per kilogram. max 1 g, once daily, 10 days. Poor compliance or oral therapy not tolerated. Benzathine penicillin, IM, and LT 10 kg 450,000 units, 0.9 ml, 10 and LT 20 kg 600,000 units, 1.2 ml, and GT 20 kg 1,200,000 units, 2.3 ml. Single dose. Hypersensitivity to penicillins, exclude immediate hypersensitivity. Cephalexin, oral, 25 mg per kilogram, max 1 g, 2 times daily, 10 days. Anaphylaxis to beta-lactams. Azithromycin, oral, children, 12 mg per kilogram, max 500 mg, once daily. Adults, 500 mg once daily. 5 days. Second-line therapy for improved oral adherence. Management of suppurative complications. Antimicrobial recommendations may vary according to local antimicrobial susceptibility patterns. Please refer to local guidelines. Disease. Peritonsillar abscess, quinsy. Odynophagia/dysphagia, pooling/drooling. Hot potato voice. Trismus. Peritonsillar swelling/erythema. Uvula deviation. Management. Refer to Ent. For consideration of drainage. Antibiotics. Benzylpenicillin 50 mg per kilogram, max 1.2 g, for 6 hourly. Switch to oral therapy. Phenoxymetyl penicillin 15 mg per kilogram, max 500 mg, oral twice daily to complete a total of 10 days of therapy, 4 plus oral inclusive. Retropharyngeal/parapharyngeal abscess. Fever, odynophagia/dysphagia. Neck swelling/tenderness. Particularly in young infants. Torticollis/neck stiffness. Retropharyngeal bulge. Refer to Ent. For consideration of imaging and ongoing management. Investigate. Lateral neck X-ray. Normal X-ray does not exclude the diagnosis. CT with 4 contrast is the imaging modality of choice when required. Should only be performed with advanced airway management available. Antibiotics. Amoxicillin/clavulanic acid 25 mg per kilogram, max 1 g, for 8 hourly. Switch to oral therapy. Amoxicillin/clavulanic acid 22.5 mg per kilogram, max 875 mg, oral twice daily. Epiglottitis/bacterial tracheitis. Abrupt onset. Respiratory distress. High-grade fever. Toxic looking. Odynophagia/dysphagia. Stridor. Muffled hot potato voice. Tripod position with neck extension. Cervical lymphadenopathy. Increased risk in children unimmunized to HIV. Blank. Defer all invasive examination/procedures/imaging until advanced airway management available. Early ICU/anesthetic/Ent review. Antibiotics. Ceftriaxone 50 mg per kilogram, max 1 g, 4/IM daily for 5 days. Consider. Dexamethasone 0.15 mg per kilogram, max 10 mg, oral/4/IM/stat, repeat in 20 hours PRN. Consider consultation with local pediatric team when systemically unwell. Suppurative complications are present. There is evidence of moderate/severe dehydration. There is significant pain poorly responsive to simple analgesia. Consider consultation with pediatric/Ent outpatient follow-up when 7 episodes of sore throat/tonsillitis in 1 year. 5 infections/year for 2 consecutive years. 3 infections/year for 3 consecutive years. Recommendations may differ, please refer to local referral guidelines. Consider transfer to tertiary center when there is evidence of acute suppurative complications e.g. abscess formation. There is evidence of upper airway obstruction. Significant comorbidities are present, e.g. immunosuppression, after discussion with relevant treating team. Consider discharge when pain relief is adequate. Tolerating appropriate oral intake.